care testing. Point of care means that you actually do the analysis at bedside. So you draw the blood right there from the patient, and you actually do the analysis right there in the room many times. This reduces turnaround time and thus should improve and lower costs. Used increasingly in hospitals and physicians' office, especially like in the emergency room. Many times if they're doing serial glucose measurements. When you do these point of care testing, they can be used for different types of analysis. In other words, you might have a blood gas analysis, you may have a glucose analysis, you may have Kindle 7, an H&H. So you just have to make sure that you obtain the correct cartridge for the analysis that you're doing. The following is a demonstration of how to use the iStat. The iStat is used at medical center. It is a point of care, and that's pretty much their go-to equipment. You typically do still have to have a lab meaning a blood gas lab, and still have cabinet style equipment to use, especially for correlation if you have to change your analyzers. But they're going to the point of care almost exclusively unless the freestanding is required, the lab analysis is required.
I'll talk to you today about having to use the iStat. So let's get started with the iStat. When you turn the iStat on, you may see that the simulator is required. This is required every 24 hours. Will not let you run a patient if you don't perform the simulator test. This is what the simulator looks like, or the box. We keep this in the laboratory. This is what the actual simulator itself looks like. It's got some metal electrodes on the end. You want to avoid touching those. On the iStat itself, to run it, it says that the simulator is required. So you're going to go menu. You're going to do 3 for quality tests. And the only choice that you have is simulator. 4 for simulator. It's telling me to scan or enter the operator ID. You can use your badge number. Anytime that you manually enter something on the iStat, you're going to have to enter it 2 times. Now it's asking me to scan or enter the simulator ID. This can be tricky to find. I've tried to highlight it in yellow. You probably won't be able to see that. But it is there right on the end of the box. So all you do is turn the simulator. There's a scan button here. You hold that, scan it, it'll beep, and then it says insert the simulator. It says contacting the simulator, please wait. You can hear it making a little noise. That's okay, that's normal. Okay, well that's doing its thing. We'll talk a little bit about the iStat cartridges, what tests are available on those, when the appropriate time to use them is, what the specimen type is, etc. By the way, the simulator takes about 120 seconds, about 2 minutes to do it. Most of the tests on this take only about 2 minutes, so especially at night, this can be useful for you if you're really needing some results in a quick hurry on a patient. Supplies and storage, we keep these cartridges refrigerated, so you'll find these in the med dispense. On A, we'll keep the Chem 8 profile, which basically does what it says, a Chem 8 and a H&H. We'll also keep the EG7 cartridge, that's for ABGs. You'll also get an H&H off there as well. All the other cartridges are stored in the laboratory. We do also have a creatinine that's mostly used by radiology. For nursing purposes, you guys will probably just be using the Chem 8 or the EG7. Once we take those out of the refrigerator, they have very short expirations, room temp expirations, so we want to make sure that we keep them in the refrigerator. Don't take them out until you are ready to use them. our simulators pass, and it says so. So we'll just take that out, make sure you recover the contact, put it back in the box, back in the drawer in the lab where you found it. We only have one, and we have to have it. We'll get back to this in just a sec. Again, you cannot run a patient if you don't perform the simulator. Specimen collection is pretty straightforward. It takes a very small volume, about 95 microliters. So if you draw 1 mil in a straight syringe, you're good. The most important thing with the iStat is to have everything prepared and laid out and ready before you draw your specimen. You can draw one of two ways. You can either draw in a heparinized syringe. That'll give you a little bit more time, or you can draw in a plain syringe. We'll draw actually in a plain syringe for the demonstration, and we're going to use a Chem 8 cartridge for the demonstration. You want a venous stick. You want to observe all standard precautions. Let's see. So once your simulator is done, you're going to go back to your menu. Okay, so you have two options. You can either see your last result, which is option 1. Option 2 is to run a test, a cartridge. So we're going to hit 2 to run. And again, it's asking for my operator ID. So I'm going to enter that. Anytime you enter it manually, it's going to ask for it twice. All right. So I've entered that. Now it's saying to enter or scan the cartridge ID number. Cartridge. Here's what a cartridge looks like. This is actually an expired one, but we're going to use it for demonstration purposes. So you would pull this out of the refrigerator, let it sit for 5 minutes at room temp before you would actually perform your test. The barcode is here on the top. So all you do is line it up, and you can hear it with a little audible beep, and it's telling me to insert the cartridge. Okay, so we're ready. Put your gloves on. Get your patient prepared with a tourniquet. Check your patient ID. Make sure you're getting the right person. But like I said, the most important part of this is to make sure that you have all your pieces prepared before you draw your patient. What will happen if you don't is that if you're using just a plain syringe, your specimen could clot off in the syringe before you are able to load it into your cartridge. So I'm opening my cartridge. You want to wait till you're ready to run. Open your cartridge. Okay. Let me draw my patient. This takes a very, very small amount of sample. You want to do a venous stick if it's on the Chem 8. The EG7, you want an arterial stick. Most of the time, it's going to be respiratory therapy who's going to be doing the ABGs. Come in on this one, Rachel. There's a very small hole here. This is where we're actually going to place our specimen. And you'll see it fill up and go into this little area right here. Okay, so that's plenty. All right, what you're going to do, if you hold your finger here, this little flap will go over. Don't worry if you have a little mess, it doesn't matter. What you want to make sure you have is some blood running into this little capillary area here. Once you get it all closed up, there's kind of a little thumb piece here you can grab to insert it. At the end, the same place where we inserted the simulator, you'll hear it click. And 2 minutes to result. Don't try to pull the cartridge out. Once it's in there, it's in there. You'll hear it making some noise, and it's telling us that it's identifying the cartridge, and it's asking you to please wait. have results, and this is what it's going to look like on the screen. Okay, you can actually use the left arrow because there should be 2 pages of results. Okay, so from here you can manually copy that onto your results sheet, or if you have the printer available to you, there's a little infrared area here, and there's an infrared area here on the analyzer. So you just line those up. There's a print key. And you get your results printed out. You can actually just tape that right on there. Make you a copy.
Transcutaneous monitoring. What does that mean? That means across the skin, right? And now we're also talking about monitors, not analysis. So it's a non-invasive form of evaluating blood gases. These transcutaneous monitors, they provide continuous non-invasive estimates of PO2 and PCO2 using a skin sensor. The sensor warms the underlying skin to increase arterial blood flow, and it warms it to about 42 degrees Celsius is the upper limit there, I believe, which is pretty hot, and so you have to be careful about causing burns on the skin. The 2 most important factors influencing the accuracy of the transcutaneous monitors are age and perfusion status. Low perfusion and increasing age reduce agreement between the transcutaneous monitoring value and the arterial value. So agreement between the CO2s, the transcutaneous CO2 and the arterial CO2 is better because the CO2 is more diffusible through the skin. Many times you'll hear these called TCOMs, TCOM, and that's what they're talking about. The most common sites for the electrode placement on the TCOM for infants and children are in the abdomen, the chest, and lower back. And in some instances, you'll actually have a couple of these in place when you're trying to watch for a patent duct or continuing shunt on the newborn, trying to watch it and see if it closes or not. And so you'll have different values on different sides of the shunt there. You should compare the monitor reading with those obtained with the concurrent ABG. So that's why you check your validity there, is you compare the actual reading at the time that you draw the blood gas to the value on the blood gas and see how they correlate. So that validation with ABG should be repeated anytime the patient's status undergoes a major change. And so having these monitors, they don't replace analysis. You still may need to do the blood gas analysis in the event of a patient's status change, but as long as things are continuing to go as expected, then probably the monitor is reasonable, and we don't have to subject the patient to a puncture or other blood draw. To the left here is figure 18-7 on page 399. This is an actual drawing of a transcutaneous monitor electrode. In other words, this is the part that's going to be put on the skin. And underneath this electrode, on the very bottom here, there's going to be a membrane of some sort that is actually supposed to come in contact with the skin. Now, it may not come in direct contact because a lot of times you'll put gel between the electrode, just some kind of jelly substance. I don't know what it's called, but it's a gel. You put it on there and you actually place the electrode on the gel, and then you tape the electrode down, and it provides for better measuring, better contact. And so without that gel, then you don't get good readings at all. But that's what this is, and you see it's got that heater on there. And again, to about 42 degrees Celsius. So you have to change this in regular interval every 4 to 6 hours. Because if you don't, it's going to burn them right there if you leave it there all the time. It'll burn their skin, and so then they'll have a little burn there that's an additional source for infection to occur. So as we heat the skin up, what it does is it increases the diffusion of gas through the skin, and that's the way this thing can work. And so that's what this one on the right hand side is saying. On the bottom right is showing you that you have to heat that to improve enough across the skin so that we can get them measured. Another thing too about this top part is this desk unit. You have the ability to set alarms for high and low CO2s and PO2s. So it's certainly an advantage there. Another thing that the TCOMs are used for is to assess blood flow in the event of, say, something like a snake bite, something that might cause a swelling. Let's say it's either in your leg or your arm area, and you want to make sure that you're getting blood flow past the swelling. And so what they'll do is they'll typically place 2 or 3 of these electrodes along the arm or along the leg, whichever one you're trying to evaluate, and make sure as long as all the readings are the same, you have good blood flow throughout. But if they start changing, let's say you have the problem is at your knee and your leg, and so you would have one electrode placed on the upper leg, one on the knee, and then one down towards the foot. Well, if the knee is the thing that's swelling, then it's likely that the one on the upper leg and the knee will be of normal value, and then the one at the foot would be decreased, and so you'd be able to watch the blood flow in an instance like that.
Continuous and non-invasive monitoring of blood gases. Transcutaneous monitoring provides critical data about a patient's ventilation and oxygenation status when frequent invasive blood sampling is not adequate. When you breathe, oxygen is transported from the air into your blood vessels via the lungs, and carbon dioxide is released. The heart pumps the oxygenated blood into the body's circulatory system, where it provides oxygen for all vital processes in the body. The cardiovascular system transports the carbon dioxide that is produced during cell metabolism back to the lung, where it is exhaled. Inside the skin's capillaries, the blood flows just 1/10 of a millimeter below the skin's surface. The transcutaneous sensor is placed on the skin, where it elevates the temperature in the underlying tissue slightly above body temperature. The body reacts by letting the skin breathe, allowing for gas diffusion through the skin. The sensor registers the quantity of oxygen and carbon dioxide present in the blood. If the levels of oxygen and carbon dioxide in the body are out of balance, this could indicate that one or more of the body's vital functions are altered and that the patient's condition could worsen rapidly. Continuous monitoring allows for a fast response to changes in patient status and for timely intervention to ensure the best possible patient care. Let's look at the clinical settings where transcutaneous monitoring makes a real difference. Abnormal oxygen and carbon dioxide levels in preterm neonates can lead to severe cerebral damage and eye and lung complications. Transcutaneous monitoring allows for immediate detection of changes in oxygen and carbon dioxide to ensure a better outcome. For patients under non-invasive ventilation, it is vital to have real-time data on ventilation and oxygenation status in order to allow proactive ventilator manipulations and tailored therapies. In sleep labs, transcutaneous monitoring supports the diagnosis of sleep-related hypoventilation syndromes and helps create an undisturbed sleep environment for patients. In the ICU, where every minute counts, continuous monitoring offers a reliable approach to accurately titrate ventilator settings for patients with acute respiratory failure. During anesthesia, transcutaneous monitoring continuously keeps track of carbon dioxide levels to avoid complications in sedated patients. For patients with severe wounds, transcutaneous monitoring is used to assess healing probability, adequate amputation level, and treatment effectiveness. Transcutaneous monitoring provides continuous and non-invasive monitoring of blood gases and offers proactive rather than reactive intervention to critical changes.
And now intra-arterial monitoring. Potential benefits of, well, I guess this is actually analysis since it's invasive, but actually what goes on here with this intra-arterial reading, this continuous reading, is you don't remove any blood. You do place a catheter in the artery, but you don't withdraw any blood. So it provides you real-time monitoring, has a reduction in therapeutic decision making time, so I don't have to wait on my results to get back from the blood gas lab. It reads them out right there on the monitor. You have less blood loss. You have lower infection risk because you're not having to puncture them as often. It has improved accuracy and elimination of specimen transport. And this is figure 18-13 on page 402. This is the innards, a cutaway, if you will, of that intra-arterial catheter. You see it's got a heater there, and it's got a O2 fiber that monitors the PO2 and the CO2 fiber that monitors the CO2, and then also a pH. So this thing just sits in the artery, and that's the way you get your continuous reading. The extra-arterial or Ex-Vivo method is very similar to an art line, except that you don't actually remove any blood. So what this does is it eliminates all the problems associated with those indwelling catheters. You can get results back in 1 to 2 minutes, but you don't get real-time continuous data. And of course, they always say further justification and cost needs to be looked at. So this is figure 18-14 on page 403. This is a schematic of an extra-arterial. And so you see that it looks very similar to an art line, and in fact it is similar to an art line in that you have pressure measuring capabilities here by the pressure transducer. But in addition, you have the blood to the gas monitor and display. So what you do here is you actually pull the blood over these analyzing electrodes that are over here, and then when you're finished, you actually push the blood back into the artery. So you don't ever actually remove the blood from the patient. You pull it out temporarily, run it over these sensors, get it measured, and then put it back in.